Let us formally start our session with recitation. Alhamdulillah. So, I would likely request you to please sit on your seats, stand up on your seats for a national anthem. Well, it is truly an honor and privilege for me to moderate this session this morning. I am Dr. Mehwish Iftikhar, Assistant Professor Endocrinology at Services Institute of Medical Sciences, Lahore. So, today, as we begin this very important session, I am reminded of timeless words of René Descartes. I think, therefore I am. This thought carries a very deep meaning because every diagnosis starts with thinking. Every hormone tells us a unique story, and every symptom asks us to pause, connect, and understand the human body, not merely as an organ system, but as a beautifully balanced universe. So this spirit of excellence we will carry, and I warmly welcome you all to second scientific session of day 2 of this conference. So our today's program carries some dynamic areas of endocrinology, from cardiometabolic risk to severe hypertriglyceridemia, and some targeted pituitary therapies to practical approach to indeterminate adrenal masses. So before beginning our session, it is my honor to call our respected chairpersons on the stage. Our first chairperson, Professor Zaman Shaikh. I would like to request you, sir, to kindly join me on the stage. I think he will shortly join us. And our next chairperson, Professor Khalid Usman, a highly respected clinician, educator, and academic leader from Postgraduate Medical Institute, Hayatabad Medical Complex, Peshawar. Sir, I request you to please join me on the stage. Next, joining our distinguished panel of chairpersons is Dr. Waqas Shafiq, a respected endocrinologist from Shaukat Khana Memorial Cancer Hospital and Research Center. With his dynamic academic leadership, he is continuing to contribute to advancements of endocrine care both nationally and internationally. Kindly join us, sir. Thank you, professors. Your presence needs tremendous value to this session. Starting our first presentation, our first speaker, Dr. Nadeem, an endocrinologist, a medical educator, founder of National Institute of Advanced Endocrinology and Metabolic Sciences, and he is affiliated with Jinnah Medical and Dental College and Mehman Medical Institute Hospital. Today, he will talk on hidden cardiometabolic risk in South Asians. So please, ladies and gentlemen.
Hello. Okay, thank you, Mehwish, for such a kind introduction. And today we are going to discuss a very important topic. As an educator, as an endocrinologist, as the diabetologist, or as general physician, you people might have gone through different presentations from me, or even you people might have presented on different forms for last 4.5 years, and most of the time your first question was, do people know that Pakistan is on which number as far as prevalence of diabetes is concerned? So I have gone through many presentation. हम स्टार्ट करते हैं और ऑडियंस की अटेंशन लेने के लिए हमारा पहला सवाल पिछले 4 साल से यही होता है कि डू यू पीपल नो दैट on which number we are as far as prevalence of diabetes is concerned? Or you are presenting in a cardiology conference and then you start with the, do you know that on ischemic heart disease or the cardiovascular disease we are on number which number as far as prevalence is concerned? So answer usually comes as we are number 1 as far as prevalence is concerned. Then our second question is why. जब आप ऑडियंस से पूछते हैं या जब आप ऑडियंस बैठे होते हैं और आपसे आपका स्पीकर पता करता है कि व्हाई वी आर ऑन नंबर 1 एज फार एज प्रेवलेंस ऑफ दिस ड्रेडेड मेटाबॉलिक एबनॉर्मलिटीज इज कंसर्न, सो व्हाट्स द आंसर यूजुअली? आप लोग ज़ाहिर लेक्चर देते होंगे और इस किस्म के सर तो डेफिनेटली ये क्वेश्चन अक्सर पूछते हैं, क्या जवाब आता है? लाइफस्टाइल, शायद खाने पीने की हैबिट्स हमारी ख़राब हैं, शायद हम लोग एक्सरसाइज नहीं करते हैं, या शायद सारा कसूर हमारा अपना ही है. हैव यू एवर थॉट दैट देयर इज समथिंग एल्स? कोई ऐसी चीज़ है जो हमें दूसरे लोगों से डिफरेंट बनाती है, जो हमें डायबिटीज़ की प्रेवलेंस में, मेटाबॉलिक एबनॉर्मलिटीज़ की प्रेवलेंस में, इस्कीमिक हार्ट डिजीज़ की प्रेवलेंस में पहले नंबर पे लेके जाती है. एंड टुडे वी आर गोइंग टू डिस्कस दैट, the uncovering of hidden cardiometabolic risk in the South Asian population. Here is my speaker disclosure. Nothing special to disclose. Ground rules are very simple. Kindly put down your phone on silent mode. So this is not a lecture जिसमें मैं बोल रहा हूँ और आप लोग सुन रहे होंगे. This is an interactive session. We will be solving some real life cases, some cases which presented to me in my OPD. Then we solve those cases. और हम discuss करेंगे कि how we are going to solve these cases to protect the lives of maybe 1,000 more lives than we currently are. So are you people with me during this journey of protection of more lives? What is the single factor which is constant across all the definitions of metabolic syndrome? We all know that HDL levels and triglyceride levels and maybe diabetes and hypertension, लेकिन एक ऐसा factor है जो probably constant रहता है तकरीबन सभी definition में metabolic syndrome के. Is anyone going to tell me? The obesity and the insulin resistance, the waist circumference. So that single factor is almost constant in almost all the definitions of metabolic syndrome. Now question arises, what lies behind obesity? क्या है obesity में ऐसा कि metabolic syndrome में obesity का होना, whether it's central obesity or the obesity presenting with insulin resistance, is mandatory? So obesity is concerned starting from brain with strokes, it's concerned with ischemic heart disease, it's concerned with the peripheral vascular disease, it's concerned with the MASH, it's concerned with many other abnormalities which are either essentially or the combination of different parts of the metabolic syndrome. Probably that's the reason जब आप जड़ को पकड़ लेते हैं, जब आप बेस को पकड़ लेते हैं तो आपको आइडिया हो जाता है कि how you are going to target the actual target, and that actual target is definitely to protect the lives of the patient, to protect the patient from stroke or ischemic heart disease or a peripheral vascular disease or even the orthostatic hypotension or the orthopnea or the obstructive sleep apnea. So all these things are actually making the lives of your patient like a living hell. And as a physician or as an endocrinologist, it is your responsibility कि आप अपने patient को वहाँ से वापस लेके आते हो जहाँ वो अपने व्हील चेयर पे बैठा होता है. मेरे पास जब कोई पेशेंट 112 kg के साथ व्हील चेयर के ऊपर आती है और उसका HbA1c में भी 12 या 12.5 होता है, और वही पेशेंट जब 6 months के बाद अगेन प्रेजेंट टू मी विथ अ वेट मे बी 98 kg and she is actually running or she is actually walking on her feet, so the joy on the face of that patient is actually the gain which you are gaining. And today we are going to discuss what is the pathophysiology कि हमारे पास हर चौथी पेशेंट किसी व्हील चेयर के ऊपर 110 या 112 kg वेट के साथ आ रही होती है. And for that we have to discuss a few cases here. Now this is a real life case. So this guy presented in my OPD, Mr. Ahmed, is a 38-year-old male office worker in Pakistan. Background is sedentary lifestyle, no known comorbids, father has type 2 diabetes, complaints of fatigue and mild weight gain. Height is 170 centimeter, weight is 69 kg, BMI is around 25, 24.9, and blood pressure is 138/88. Fasting blood glucose is raised, HbA1c is raised, triglyceride is raised, and HDL low. So essentially this patient is fitting the criteria of metabolic syndrome. That's how it is. Now question arises, this patient have got a normal BMI. Now, how a patient with a normal BMI can present to you with all other combinations of the metabolic syndrome parts? Who is going to tell me? आप लोगों के ख्याल में क्या फैक्टर है जो यहाँ हमें इस पेशेंट को मेटाबॉलिक सिंड्रोम के अंदर लेके आ रहा है? So number one, visceral obesity, but I haven't deliberately given visceral obesity here. So कुछ और? 23 BMI is a cutoff for Asian population. So actually WHO criteria of 25 BMI for overweight doesn't apply to us, the Asian population. We have got a different criteria. हमारा criteria different है, हमारे normal ही different होते हैं. We start our overweight with a BMI of 23. Then from a BMI of 25, we are essentially obese. And probably the definition or the indication of starting different medication starts right from a BMI of 25 in Asian population. The Asian dilemma, which I was already discussing, that Pakistan on number one as far as prevalence of diabetes is concerned, Pakistan on number one as far as prevalence of even ischemic heart disease is concerned. Even in South Asia, data कहता है कि ischemic heart disease के अंदर हम पूरी दुनिया को लीड कर रहे हैं. तो शायद अच्छी चीज़ों में तो ना करें, लेकिन बुरी बुरी चीज़ों में हम दुनिया को लीड करते जा रहे हैं. क्वेश्चन ये उठता है, why? So these are the learning objective. Why Asian cutoffs are different? Now that's very interesting. Why our BMI is 23? Why 80 centimeter is our central obesity parameter as compared to the Caucasian population? Ji sir. Yes. Why? जैसे मैडम ने कहा था ना कि medicine is thinking. So have we ever thought that why we are different from Caucasian population? क्या ऐसा हुआ पिछले 200, 300 या 400 साल के अंदर कि हम किसी अच्छी जगह से किसी बुरी जगह की तरफ मूव करना शुरू हो गए? Have you ever thought? So probably शायद जो डिफरेंस है, जो प्रॉब्लम है, वो शायद बहुत पहले से चला आ रहा है, मे बी 1500 या 2000 साल से. कुछ और? वेरी गुड.
लेकिन उसके साथ हमारी जो है वो लाइफस्टाइल तो मैकेनाइज्ड हो गया है, लेकिन हमारा जो है बेसिक डिपेंडेंट राइस एंड व्हीट है.
That's wonderful. That's the actual answer. Sorry, थोड़ा सा कट करना पड़ा, टाइम का कंस्ट्रेन है. ताहिर ने कहा कि 20 मिनट में पूरा करना है. So we Asians are different probably because के पिछले 200, 300 या 400 साल के अंदर हम लोग स्लेव रहे हैं. We are basically not the well-nourished society for last 400 or 500 years. Maybe slave हो सकता है कि हम US, UK वालों के हों या शायद यहाँ अभी किसी monetary fund के हों, but we are slaves and our mothers haven't been fed well for last 300 or 400 years. Our early kids haven't been fed well. तो अल्लाह ताला क्या करते हैं? God nature always tries to protect इसके बंदे. तो अल्लाह ताला ने क्या किया? हमारे जीन्स में चेंजेस पैदा किए, सो दैट वेन एवर वी टेक सो लिटिल एनर्जी वी ट्राई टू कंजर्व दैट लिटिल एनर्जी, ताकि आगे जब हमें खाना ना मिले तो हम उस लिटिल एनर्जी से अपनी जिंदगी बचा सकें. दैट्स वी कॉल एट द मेल न्यूट्रिशन मेटाबॉलिक प्रोग्रामिंग hypothesis. That's a hypothesis, but that's a valid hypothesis with a strong data behind that. अब एक और प्रॉब्लम हुआ. We Asian have got adipose tissue expansibility not as much as the Caucasian population. तो जब हमने बहुत सारा फैट जमा करना शुरू किया तो वो फैट एक्चुअली हमारे सबक्यूटेनियस टिश्यू में फिट नहीं आ पाया. सो दैट फैट वर डायरेक्टेड टू द विजरा. सो दो हाइपोथेसिस हैं जो ये कहते हैं कि प्रोबेबली फॉर लास्ट 200 और 300 years because we were slaves and our mother were not fed well, what happened? We actually tried to conserve the energy and that energy was converted into definitely fat, and then that fat was diverted to probably our liver and our different viscera. अब जब हमें बहुत सारा खाना मिल गया और हम वेल फेड हो गए तो वो फैट बढ़ता चला गया. Probably that's the reason, because of these two hypotheses or two theories, we have been actually gone more prone towards the development of different abnormalities. Now एक और केस डिस्कस कर लेते हैं. This again a real life case presented in my OPD. Mr. Imran is a 41-year-old banker. Sedentary job, long sitting hours, high refined carbs, no known chronic illness, family history of type 2 diabetes. Now, height 168 centimeter, weight 66 kg and BMI even with Asian cutoffs is normal. But waist circumference is 96 centimeter. If you look at the parameters, again all the parameters of metabolic syndrome are fitting in. अच्छा, उस पेशेंट में तो BMI बढ़ा हुआ था, 23 से ज़्यादा था. ये तो एशियन पैरामीटर के BMI में भी नॉर्मल है. Yet this patient is fitting in all the parameters of metabolic syndrome, and these all are real life cases. ये वो लोग हैं जो हमारे पास OPDs में आते हैं, and you people might have encountered these type of patients in your OPD as well. So question arises, why a patient with a normal BMI is again presenting here in our OPD with a metabolic syndrome parameter? Who is going to answer that? Here comes your answer कि इस पेशेंट के अंदर अगर हम वेस्ट सर्कमफेरेंस को देखेंगे, सो वेस्ट सर्कमफेरेंस इज 96 सेंटीमीटर, विच इज वे टू हाई फॉर एन एशियन पॉपुलेशन. सो आवर वेस्ट सर्कमफेरेंस इज अगेन हाई. द सेम स्टोरी अप्लाइज हियर. बहुत सारी लिपिड, बहुत सारी चर्बी जमा हो गई, हमारे विजरा के ऊपर आ गई, एंड देन डेफिनेटली दिस सेंट्रल ओबेसिटी हैज डेवलप्ड. सो आवर पैरामीटर्स आर अगेन डिफरेंट हियर. इफ यू लुक एट द पैरामीटर्स, तो ये रहे हमारे पैरामीटर्स जो हमें ये कहते हैं कि इन एशियन पॉपुलेशन, सॉरी, दिस वन मोर देन 80 centimeter for Asian female and more than 90 centimeter for an Asian male is called as central obesity. So if a patient is presenting with even a normal BMI, you have to go through either the waist circumference or waist hip ratio, and if waist circumference is high, data क्या कहता है, that patient is very much prone to development of insulin resistance and type 2 diabetes and atherosclerosis and non-alcoholic fatty liver disease and hypertension and cardiovascular disease and so on. So data नीचे आपको references नजर आएंगे. The strong evidence, एक थिन लीन पेशेंट जिसका सिर्फ सेंट्रल ओबेसिटी है, is going to develop a lot of metabolic problems, and we have to protect that patient from developing those problems. So this patient is again a candidate of therapy if we want to protect this patient. Now this one is very interesting. So दो पेशेंट हैं, अच्छा ये भी रियल लाइफ है. वन इज मिस्टर अली, डिफरेंट एरा के अंदर इन पेशेंट्स ने मेरे पास प्रेजेंट किया था, बट लुक एट द कंपैरिजन ऑफ दिस पेशेंट. वन इज मिस्टर अली, 35-year-old with a height of 172 centimeter, weight of 72 kg. Look at the BMI. दोनों का BMI is almost same है, 24.3. One is physically very active, goes to gym for 4 to 5 times a week, and other one is has got the sedentary lifestyle. Now look at the metabolic parameters. Mr. A have got a fasting blood glucose of 92, HbA1c of 5.3. Mr. B have got a fasting blood glucose of 110, HbA1c of 7. Now look at this waist circumference, दोनों की 85 सेंटीमीटर है. So now that's interesting. दो cases आपके पास दो different areas में present करते हैं, essentially not fitting in the criteria of either central obesity or obesity. Weight भी same है तकरीबन, BMI भी same है, even waist circumference भी same है. Yet we have got different parameters. And these are the real life cases which you are going to encounter in your OPD. Now the question arises, अब क्या किया जाए? Because we are going to find out how our patients are presenting with essentially normal BMI or even normal waist circumference in our OPDs with different parameters fitting in of the metabolic syndrome. Question, same weight, same waist, yet different risk. Who is going to answer the answer of this question? Sir, muscle mass that matters, and how we are going to identify the muscle mass. Now that's the question number 2. Very good. Body fat composition. So in these patients, because we have got body fat analyzer in our OPD, in our institute, so this is called as trophy, thin outside, fat inside. Patient बाहर से thin है, patient का central mass बिल्कुल ठीक है, yet the patient have got different parameters, and this is called as bioimpedance analysis of two different patients, patient A and patient B, and look at the fat level of patient A and patient B. Do we have a pointer here? Because this one is I'm definitely going to need. Now look at the body fat parameter here. The visceral fat here is very high as compared to visceral fat here. Same central obesity, same waist circumference, same weight, yet the different results. And whenever we started to treat this patient, we actually considered this patient right fitting in some definition of the metabolic syndrome and started maybe metformin और जो भी चीजें आप start कर रहे होते हैं. So actually this all started maybe 400 years ago, but these patients are presenting to us in our OPDs. तो अगर आपके पास कोई patient आता है जो अपने आप को बहुत thin और fit समझता है, yet this patient when checks his blood glucose level and comes out to be 100 or 110 or HDL level of around 30 or triglyceride level of 250, so straight away उस patient को ये नहीं कह देना कि you are very much fit and you have nothing to worry about. That patient is definitely going to require for some type of weight loss or even some type of fat loss in order to improve the obesity related complication. Question arises, how much weight or fat loss is required to reverse some type of the complication? आप लोगों का target क्या होता है whenever you are treating a obese patient? सबसे पहला target क्या होगा? Whenever we say that our therapy or our diet plan is failing, आपने किसी पेशेंट को डाइट प्लान दिया, मे बी थेरापी दी, पेशेंट को 3 मंथ्स के बाद बुलाया, आप लोगों के ख्याल में व्हाट्स योर टारगेट, कितना वेट लॉस हो जाए तो आप कहते हैं कि नाउ योर थेरापी इज एक्चुअली वर्किंग? 1% है, 5%, दैट्स द आंसर. सो इफ योर थेरापी इज फेलिंग, इट मींस लेस देन 5% वेट लॉस इज नीडेड. आप लोगों के ख्याल में 5% वेट लॉस हो जाए तो कौन कौन सी बीमारियों को रोका जा सकता है? So you're going to choti moti bimariyan, that's the right answer. So you can actually control hypertension and hypertriglyceridemia. If 5 to 10% weight loss, then PCOS and dyslipidemia. And the famous direct study क्या बताती है, अगर आपके patient का first 6 month के अंदर 10 to 15% weight loss हो जाए, essentially 80% of your newly diagnosed patient are going to reverse their diabetes. That's how weight loss is important. That's how weight loss is going to work for your patient. Now question arises, how to lose weight? That's the actual question, because I'm not going to talk a lot about the treatment option. My topic was essentially finding the reason behind all these things. Maybe someone other is talking about the treatment option, but एक दो स्लाइड जरूर डिस्कस कर लेते हैं, कैसे अपने पेशेंट को वेट लॉस की साइंस समझाते हैं. Very good. That's the answer. So it's not a rocket science. You ingest calories and you burn calories. If your ingestion is high and burning is low, you are going to gain either weight, or even अगर आप weight नहीं भी gain कर रहे हैं, you are going to gain fat. यही अपने पेशेंट को मैं समझाता हूँ. आपकी इंजेक्शन कम कर दें, वेरी गुड डाइट प्लान. वी हैव गॉट डेडिकेटेड डाइटिशियंस इन आवर क्लिनिक्स. दे हैव गॉट डेडिकेटेड एक्सपीरियंस फॉर ओबेसिटी एंड दे गिव अ वंडरफुल डाइट प्लान. खुद से नहीं देना, क्योंकि आप नहीं जानते हैं कि पेशेंट की कैलोरी को कैसे कैलकुलेट करना है. एंड देन द एक्सरसाइज प्लान इज डेफिनेटली गोइंग टू इंक्रीज द कैलोरी बर्निंग एंड योर डाइटिशियन और डाइट प्लान इज गोइंग टू डिक्रीज. जब मैं किसी को GLP-1 एनालॉग्स देता हूं तो अक्सर पेशेंट मुझसे पूछते हैं, डॉक्टर साहब मेडिसिन खत्म हो जाएगी फिर क्या करेंगे? तो माय आंसर इज दैट जब मेडिसिन खत्म हो जाएगी तो हम आपको ऐसा डाइट चार्ट देंगे कि यू आर नॉट गोइंग टू गेन वेट. एंड दैट हैपेंस बिकॉज आई हैव बीन प्रैक्टिसिंग मेडिसिन एंड ओबेसिटी फॉर लास्ट 2 years. ओबेसिटी में बहुत एक्सपीरियंस है मेरा. सो हमने GLPs बंद करने के बाद लोगों के वेट गेन को रोका है. माइट भी किसी और एरिया के अंदर हम इसको डिस्कस करेंगे ऐसे. सो दिस वाज द बेसिक प्रिंसिपल, आइदर डिक्रीज इट और इंक्रीज इट. बट द क्वेश्चन इज दैट, इज इट दैट सिंपल? क्या सिर्फ डाइट और फिजिकल एक्टिविटी से आप अपने पेशेंट के वेट को लॉस कर सकते हैं? We have some other behavioral modification as well. For example, if you are talking about sleep, अगर आपका पेशेंट रात को 3 बजे सोएगा तो डेटा क्या कहता है? If your sleep quality is disturbed, if your sleep chronotype is disturbed, or even if your sleep timing is disturbed, that is not only going to affect the weight, but glucose metabolism, blood pressure, HbA1c, lipid profile, physical function. मैं अपने पेशेंट को कहता हूँ मैं तुम्हें सब दवाइयाँ भी दे दूँ, लेकिन अगर तुम रात को 3 बजे सोओगे और दिन को 1 बजे उठोगे, you are not going to lose weight, or you are not going to so much easily control your blood glucose level and hypertension level. So diet therapy, physical activity therapy and behavioral modifications are very important if you want to encounter that high risk. ये जो high risk हम लोगों को पिछले 4 साल से मिला है, being a physician, being an endocrinologist and even being a human, this is our responsibility कि हम इसको काउंटर करें और अपने पेशेंट को ड्रेडेड कॉम्प्लिकेशन से बचाएं, जो हमने ऑलरेडी डिस्कस की हैं, दी स्ट्रोक्स, दी इस्कीमिक हार्ट डिजीज, दी पेरिफेरल वेस्कुलर डिजीज एंड ऑल दिस कॉम्प्लिकेशन. एंड द लास्ट स्लाइड इज डेफिनेटली द फार्मेकोथेरापी. So people usually ask me कि bariatric surgeon के पास जाना है. So my answer is that bariatric surgery can decrease up to 32% of weight loss, and the neuro drugs are already reached up to 30% of weight loss. So we do have pharmacotherapy, and if the indications fit in, pharmacotherapy is very important. This is conclusion. South Asians are very high risk as far as prevalence is concerned, as far as risk is concerned, and this is our duty to not only find that hidden fat inside your patient, but you have to treat, you have to counsel, you have to guide your patient to counter that hidden fat. Thank you, guys.
Thank you very much, Dr. Naeem, for the excellent presentation. One important key message I take away from yours is cardiometabolic risk is not merely judged by BMI alone. It should be adopt even more comprehensive care for health and adiposity. So it is my pleasure now to introduce Dr. Muhammad Usman Musharraf, consultant endocrinologist from Allied Hospital, Faisalabad, having fellowship in both medicine and endocrinology. Today he will speak on severe hypertriglyceridemia, an unrecognized life-threatening condition. So please join me in welcoming Dr. Usman Musharraf.
Bismillahirrahmanirrahim. Thank you, Dr. Mehwish, for your kind introduction. First of all, I would like to pay my gratitude to the scientific committee, Pakistan Endocrine Society, and my friend Tahir to get me here today. Today, I am going to start my talk with a clinical scenario that we as endocrinologists come across in our clinical practices. That is, a 42 years old female who experienced third episode of acute pancreatitis over 2 years, extensive evaluation including Endoscopic ultrasound, MRCP, autoimmune screening, genetic testing, and metabolic workup was unrevealing. During referral to endocrine clinic, a fasting lipid profile demonstrated triglycerides of 2600 milligram per deciliter. Review of record showed that triglycerides had never been measured before. So which recommendation is most appropriate for clinical practice based in this case? Option 1. Lipid profile should be ordered only after all other investigations failed. Option B. Hypertriglyceridemia should be considered early in the diagnostic algorithm of recurrent pancreatitis. Option C. Triglyceride should be measured only in patients with diabetes. And option D. Lipid screening is unnecessary when imaging studies are normal. So which is the best option in this clinical case? B. Okay, let's see. So I am going to talk about severe hypertriglyceridemia, an unrecognized life-threatening condition. These are the learning outcomes of my today's talk. We will be discussing the pathophysiology of hypertriglyceridemia, the classification and management of hypertriglyceridemia, the difference between chylomicronemia and hypertriglyceridemia, and finally, we will be discussing the recent clinical trials on 2 novel molecules on triglycerides, on hypertriglyceridemias. Okay, let's start from the exogenous and endogenous pathway for triglyceride metabolism. In exogenous pathways, chylomicrons come from small intestine in the blood through lymphatics, and lipoprotein lipase, that is an enzyme that is produced in endothelium of blood vessels. It will hydrolyze chylomicrons into chylomicron remnants and taken up by liver. On the other hand, lipoprotein lipase, it will also produce free fatty acids that are taken up by muscles for utilization and adipose tissues and liver for further storage. In endogenous pathway, liver will produce very low density lipoproteins in the blood. And again, lipoprotein lipase, it will hydrolyze this VLDL and will convert into LDL, VLDL remnants and LDL and taken up by liver again. So the rate limiting enzyme is lipoprotein lipase in both endogenous as well as in exogenous pathways. There is another substance, protein, that is ApoC3, that is produced by liver, comes in blood, and it binds on the surface of these triglyceride rich particles. And obviously it will not allow lipoprotein lipase to hydrolyze these triglyceride rich lipoproteins. So this is the mechanism we have used in novel drugs that we are going to discuss today. So the chylomicrons from intestine in the blood, they cannot enter the endothelium of blood vessels because they are too large to enter into the endothelium of blood vessels. But VLDL remnant-like particles, chylomicron remnant-like particles, IDL and LDL, they all enter in the endothelium of blood vessel and start the process of atherosclerosis. So how chylomicronemia, it will lead to pancreatitis, severe chylomicronemia, severe hypertriglyceridemia, it will produce hyperviscosity, and hyperviscosity after impaired lipolysis of remnant particles, it will end up with free fatty acid toxicity, and that can end up with acute pancreatitis. So how do we classify hypertriglyceridemia? As far as the normal triglyceride levels are concerned, we have consensus amongst all the societies about the normal triglyceride levels, you all know. But for severe triglyceridemia, what are the levels proposed by different societies? In endocrine societies, levels more than 1000 milligram per deciliter. According to AHA and ADA, levels more than 500 milligram per deciliter. According to NICE and European Society of Cardiology, levels more than 880 milligram per deciliter define severe hypertriglyceridemia. So what are the causes of hypertriglyceridemia? The causes may be the primary causes and secondary causes. In primary causes, we have familial hypertriglyceridemia, familial chylomicronemia syndrome, familial combined hyperlipidemia, and familial dysbeta lipoproteinemia, and familial alpha hypoalpha lipoproteinemia. And in secondary causes, we have diabetes, alcohol consumption, hypothyroidism, drugs like estrogen, heart therapy, and certain immunosuppressants. Then pregnancy, liver, renal diseases, and lipodystrophy. They will aggravate this existing hypertriglyceridemia. So how do we manage the patient with hypertriglyceridemia in its severe form? What are the management approaches? So this is these are the guidelines proposed by American Heart Association. According to these guidelines, if triglyceride levels are more than 500 milligram per deciliter, the refined sugar, they should be less than 5% of the total calories. And if triglyceride levels are more than 1000 milligram per deciliter, the simple carbs, they are to be eliminated from the diet. The fats, they should not constitute more than 20 to 25% of total calories if TGs are more than 500 milligram per deciliter, and no more than 10 to 15% if TGs are more than 1000 milligram per deciliter. And alcohol abstinence is advised in all classes of severe hypertriglyceridemia. 150 minutes per week of moderate intensity physical activity, 2 sessions of resistant exercises, and 5 to 10% of weight loss will have positive impact on all forms of hypertriglyceridemia. So how do we manage adults with hypertriglyceridemia in any form, in any class of hypertriglyceridemia? The first step is to address and to treat the secondary causes of hypertriglyceridemia, to advise lifestyle modifications. So after lifestyle modifications and after addressing the secondary causes of hypertriglyceridemia, the next step is to maximize statin to achieve LDL and non-HDL targets in patients with ASCVDs and hypertriglyceridemia. The first step is not to lower the triglyceride. The first step is to achieve the target LDL and non-HDL with statins and with other LDL lowering therapies. And after we have achieved these goals, the second step would be we will add omega-3 fatty acid, that is eicosapent and ethyl. So when triglyceride levels are more than 500 milligram per deciliter, after identifying the secondary causes and treating the secondary causes, and after lifestyle modifications, if persistent fasting high triglyceride levels are more than 500 milligram per deciliter, we will estimate 10-year risk of ASCVD. And if the risk score is high, again, our target would be to achieve our goals with LDL, non-HDL, and preferably ApoB. And after we have achieved all these goals, we can add fibric acid derivatives and omega-3 fatty acids to prevent the risk of acute pancreatitis. On the other hand, in familial chylomicronemia syndrome, when triglyceride levels are more than 1000 milligram per deciliter, the target is to prevent the recurrent attacks of acute pancreatitis in these individuals. So what should we do? We will add fibric acid derivatives and omega-3 fatty acid to prevent acute pancreatitis, and we can add olezarsen, a new novel molecule, ApoC3 inhibitor, obviously to lower the risk of acute pancreatitis. This is the average triglyceride reduction with different, obviously, therapies we have discussed. With very low fat diet, we can reduce TGs by 20 to 50%, with weight reduction 10 to 13%, with alcohol cessation 10 to 18%, with fibrates and omega-3 fatty acid by 30 to 50%, by statin by 10 to 30%, and single session of plasmapheresis can reduce triglyceride levels by 50 to 80% after a single session. So what is the difference between severe hypertriglyceridemia and familial chylomicronemia? So as we have discussed, the triglyceride levels of more than 500 milligram per deciliter, and in clinical practice more than 1000 milligram per deciliter, is the definition of severe hypertriglyceridemia. And presence of fasting chylomicrons in plasma with fasting TGs of more than 880 milligram per deciliter, we say this patient has chylomicronemia. Severe hypertriglyceridemia is relatively common condition. 1 to 2% adults, they have TGs of more than 500 milligram per deciliter. So 1 to 2% of adults, they have severe hypertriglyceridemia, while familial chylomicronemia syndrome is absolutely rare, with 1 to 10% in a million population they will have familial chylomicronemia syndrome, but multifactorial chylomicronemia, that is still more common, but still uncommon. The etiology of severe hypertriglyceridemia, we have multifactorial etiologies, the genetic predisposition with secondary factors. Obviously, all these factors contribute in rising triglyceride levels. They can be dangerous for, obviously, for pancreas. But defective clearance of chylomicrons, this is the key defect in familial chylomicronemia, and the mutation. In 80% of the individuals, there is mutation in gene encoding lipoprotein lipase gene. So secondary causes, obviously, they precipitate severe hypertriglyceridemia and chylomicronemia. After centrifugation in severe hypertriglyceridemia, serum will appear turbid or cloudy, while it will be milky or creamy. It will present triglyceridemia, it will present in adulthood, while familial chylomicronemia syndrome, it will present in childhood. The goal of treatment in severe hypertriglyceridemia is to reduce pancreatitis risk and to reduce cardiovascular risk, while the goal is to prevent recurrent pancreatitis in chylomicronemia. Response to conventional therapy is good if secondary causes are treated in severe hypertriglyceridemia, but response is poor with conventional treatment options in patients with monogenic familial chylomicronemia syndrome. ApoC inhibitors, they have promising results in patients with familial chylomicronemia syndrome and in patients with obviously resistant severe hypertriglyceridemia. So I will be discussing in 5 minutes about the two clinical trials. They were published in New England Journal of Medicine. The first one is BALANCE trial. It was obviously randomized, multi-centered, placebo-controlled trial over 66 individuals. They were randomized with olezarsen 80 milligram, olezarsen 50 milligram, and placebo in 1:1:1 ratio. Obviously, we have discussed the olezarsen, that is ApoC3 inhibitors, the pathology, obviously, we have discussed in our initial slides. The mean age of study population was around 47 years, and the mean BMI of the study population was 25 kilogram per meter square. 70% of individuals in the study arm, they had previous history of acute pancreatitis. And almost 30% patients, they have diabetes. The mean triglyceride levels in study population, that was around 2,000 to 2,600 milligram per deciliter. These were the mean triglyceride levels in these individuals. Most of these individuals, they were taking other lipid-lowering treatment. So here you can see the results after 53 weeks of this after randomization. You can see the triglyceride reduction with placebo. No reduction, even a bit rise in triglyceride levels after 53 weeks in placebo arm, while here you can see the yellow line. With olezarsen 50 milligram, the 32% reduction of triglyceride was achieved after 53 weeks, while 40% reduction in triglycerides were achieved with 80 milligram olezarsen. So this is a remarkable drug. Based on the drug, FDA has approved this molecule to be used for patients with familial chylomicronemia syndrome in 2024 and in patients with severe hypertriglyceridemia in June 2026. So the side effect profile, obviously, that was compared with placebo. Almost none of the patients, they experienced severe side effects in olezarsen group. Most of the patients, they experienced nasopharyngitis, headache, or some non-specific abdominal pains. So another clinical trial, the Palisade clinical trial, again published in New England Journal of Medicine. In this clinical trial, it was again randomized, double-blind, placebo-controlled trial where 75 patients, they were randomized with plozasiran 25 milligram, plozasiran 50 milligram, and placebo in 1:1:1 ratio. The mean age of study population was around 42 to 47 years, And mean triglyceride levels in the study population was around 2000 milligram per deciliter. And most of these individuals, they were already taking some lipid lowering drugs. 90% of individuals in all either in control or study arm, they had history of pancreatitis in last 10 years. So here you can see the change in fasting triglyceride levels at 10 months and after 10 to 12 months of treatment with placebo, the yellow column, with plozasiran 25 milligram, almost 78% reduction, while with plozasiran 50 milligram, around 80% reduction after a year. So this drug is even more effective than the previously we have discussed, the olezarsen, where there was some reduction in triglyceride levels, but FDA has approved this molecule to use in patients with familial chylomicronemia syndrome in year 2025. The beauty of this drug is this drug has to be taken as subcutaneous injection after every 3rd month, while the previous molecule we have discussed, the olezarsen, that has to be taken as subcutaneous injection after every month. So this is the beauty of this drug. Again, the side effect profile was more or less same. 3 patients in plozasiran 25 milligram and 2 patients in plozasiran 50 milligram and 6 patients with placebo, they discontinued this drug. Otherwise, more or less, the side effect profile was not very bad. So what are key takeaways from today's talk? Hypertriglyceridemia should be considered early in diagnostic algorithm of recurrent pancreatitis. The most important step in treatment of hypertriglyceridemia is to address the secondary cause of hypertriglyceridemia and to treat it. The goal of treatment in mild to moderate hypertriglyceridemia is to prevent atherosclerotic cardiovascular diseases, while the goal of treatment in patients with severe hypertriglyceridemia, that is to prevent future risks of acute pancreatitis. And new treatment options for familial chylomicronemia syndrome, they are the real hope for the patients who are unresponsive to the conventional treatment. With this, I conclude my today's talk. Thank you very much for your patience.
Thank you very much, Dr. Musharraf, for such a practical and clinically relevant presentation. It's true that severe hypertriglyceridemia should never be taken as just merely an abnormal laboratory result, but as a condition that require a prompt recognition and early recognition to prevent some life-threatening conditions. Dear audience, you can scan QR code for any questions you may have. It is being displayed on the stage. And meanwhile, thank you very much, Professor Zaman, Shaikh, for joining us on the stage. We are honored to have you with us today. Now, it is my pleasure to introduce Dr. Umair Ashfaq, Assistant Professor for Endocrinology from Services Institute of Medical Sciences, and he holds both in medicine and endocrinology. He holds FCPS qualification with special interest in pituitary disorders and clinical endocrinology. Today, he will speak on targeted combination therapy in acromegaly. So please join me in welcoming Dr. Umair Ashfaq.
Assalamu alaikum, everyone. Thank you, Dr. Mehwish, for the kind words. All right. Today we are going to discuss combination and targeted therapies of acromegaly. So just to, before discussing the details of this, let's recall a bit about acromegaly. And we all know that this disease is actually driven by autonomous production of excess growth hormone and then IGF-1, and that leads to the various manifestations of acromegaly, and not limited to the skeletal manifestations, but also various metabolic manifestations. So if we all agree to it, then we might be agreeing on the other fact as well, that the control of IGF-1 is actually the desired treatment goal. And this may label the patient to be cured, or maybe we can label that the disease is controlled. So I hope we agree to it. Is it so? All right, most of us agree to it. But if it is so, then we see that the various complications associated with acromegaly, which are metabolic, cardiac, renal, and not only these, but the other complications like increased risk of cancers, colon cancer, thyroid, obstructive sleep apnea, arthropathy, and vertebral fractures. So even this has been seen, then even if the IGF-1 is controlled, these complications either stay there or even progress. Like arthropathy even progress even if the disease is controlled. The IGF-1 is even controlled, then the disease even progress. Same, the risk of cancers stays there. So that's why the regional guidelines to be followed and routine screening to be done. If that is, and this is actually related to the cumulative exposure of IGF-1 throughout the life and the duration during which the how many years or months the growth hormone and IGF exposure, excess of these hormones was there. As a result, solely relying on the IGF-1 normality may not be taken as the ultimate outcome. So that's why we are here. Whether we have to decide that IGF-1 is the end of story or it's the beginning of treatment. So you see that about 1/3 of the patients, if we see the quality of life, there have been questionnaires and validated tools to check the quality of life. 1/3 of these patients shows the discordance between the IGF-1 control and the symptoms control, the quality of life questionnaire. And arthropathy continues to progress in 40 to 70% of the patients. So controlling the hormone is necessary, but it's not the same as controlling the disease. So what control actually we need? It's the biochemical control. Obviously, the IGF-1 should be brought into the age-matched range. The comorbidities, signs, symptoms, and adenoma mass effect to be controlled, definitely. We cannot deny. But remember, even if the biochemical control is achieved, these patient-reported and clinician-reported tools to guide the treatment and check the disease activity, these even show the discordance, like the 1/3 of the patients do not feel the correction of these parameters. So while going to discuss the combination therapy and targeted therapy, so we have to define the goal first, and then we have to think about the medicines, what every medicine has the impact on all these three controls, and then choosing the right drug. And we all know that transsaphenidal surgery remains the cornerstone of treatment. But in acromegaly patients, sometimes, and some of us, few of us, believe that the surgery, if done, it means that there is no further option. And even if the medical therapy is given, does not give the satisfactory control, all the control we discussed earlier. The surgery is definitely dependent upon the surgeon's hands, and it's the biggest modifiable factor. But remember, 50% of these patients ultimately need medical therapy. So the medical therapy to be given in about these 50% of patients or more, and that should be a tailored medical ladder. The various options, the drug options we have, they cannot be just give a standardized way to give one drug, then the other, and the third, fourth, or combining any two randomly. So based upon the comorbidities and other factors, this combination to be decided. Now talking about the drugs, briefly, we have somatostatin receptor ligands, octreotide acting on subtype receptor 2, and pasireotide acting on 4 out of 5 receptors, including 5. The dopamine agonist not mentioned here acts on the D2 receptors and decreases the growth hormone levels. And these SRLs also decrease the tumor mass size. On the other hand, pegvisomant acts on the liver and causes the decreased production of IGF-1. So IGF-1 control is provided with all of these drugs. But the thing is which drug to choose and when to choose. So in your practice, whenever the patient comes, These are 4 parameters, like the patient sitting in a clinic, persistently elevated IGF-1, adenoma growth, ongoing symptoms, or worsening glucose tolerance or toxicity or comorbidities. So which is a primary driver of treatment? Anyone who can just give the answer? All 4, excellent and 100% correct. Like these are all 4 parameters to be considered. So it's not just a simply IGF-1 or any one factor to decide the treatment mode of treatment. So that's very important story, to choose the right piece move. And that will change the comorbidities and progression of comorbidities and ultimately the overall control. So a patient coming with a 44-year-old patient, he has persistent acromegaly, the surgery is done and IGF-1 after 3 months of surgery, it is 2.5 times upper normal limit. On the MRI T2 imaging, there is hypointense lesion and it is densely granulated on histopathology. Glucose is normal. So what first line of medical choice? We can decide with the show of hands, like pegvisomant therapy, first generation SRLs, somatostatin receptor ligands. Anyone in favor of it? Seriotide, okay, few of them, and cabergoline. All right. So thank you very much. Almost equal votes to all of these. But again, the answer is first generation somatostatin receptor ligands. Now discussing that this drug is chosen is not based upon the fact that it's at the long-term data and so obviously first line. No, this is not the reasons. There are various predictors of response to this treatment in this scenario. And this has been proven with AcroFast study. In this study, it was seen that if it is biomarker guided, precision based treatment, targeted treatment, then the response was more and it was faster, because the quick control is also required. The more we lead to the excess exposure of growth hormone and IGF-1, the even later on, if the IGF is controlled, the comorbidities keep on worsening. So this is a very important primary driver to decide the treatment. So why we went for it in this scenario is these parameters, like hypointense lesion on MRI, T2 image, densely granulated, high, this was not written, but again high manifestation of somatostatin receptors and relatively low baseline growth hormone IGF-1 levels. So these parameters, if present, favor to decide in favor. It says to go for SRLs, somatostatin receptor ligands. So this is the like in the first line treatment, this was chosen because of these predicting parameters. And the response with these injectable somatostatin ligands is up to 80%, 17 to 80%, but realistically talking about is about 40 to 50%. So this is the oral revolution. Like these are also available as oral formulation. And the response to this is actually not more than injectables. This 58% are those patients like who were controlled on injectable. 58% of those maintained the control with the oral octreotide and with peltusotine, which is a non-peptide oral SRL, up to 83%. And this is proven by these multiple trials. Okay. So oral maintained the control, but the control was not actually that superior with the injectable. So these are not considered as a first line. But the oral improved the adherence. As a result, the patient reported tool, that is AcroQOL questionnaire, that showed the improvement. So the 3 parameters which actually want to improve, one of them showed the relative improvement as compared to injectables. So these have some space. These the side effects are similar to the injectables. The tumor mass also shrinks as with the injectables, but the long-term data is yet not available. So these are not first line, but a good option when the control is achieved with injectables. Then other option is pegvisomant. Can it be given at the very start? Yes, why not? Because this is decided on the base of fact if the diabetes is challenging, it's uncontrolled, because somatostatin receptor ligands may worsen it. Usually this as first generation SRLs do not do much bad with the diabetes, but can so even if it is already uncontrolled. And this pegvisomant is believed to increase the adenoma size because it's going to act on the liver, inhibit the growth hormone action, but growth hormone production from adenoma is not decreased. The tumor size may increase. So as a result, in the previous recommendations, it's always says to do an yearly MRI. But again, the response is in the trials it is more than 90%, but in this ACRO study registry, the response was up to 57 to 75% on real parameters. And in this it was seen that only 3% patient has shown the increase in adenoma mass size. And this was similar to patients not on medical treatment. So as a result, the yearly MRI may not be required, but again, just not to follow absolutely about it and decide patient about clinically whether the symptoms of adenoma growth are there or not, and then yearly MRI may be done. Cabergoline, again, it's a very good option. The oral drug, easily available, cheap, relatively lesser side effects, but this is like acts on the D2 receptors, but 34% of the patients show the IGF-1 control, and it can only be given if the IGF-1 level is less than 2 times upper normal limit. So modest elevation. So if it is a post-surgical high elevations, this is not going to be a first line option. So the patient was put on first generation SRL. IGF-1 is 1.6 upper normal limit. It's a partial responder. Now residual intracellular adenoma is stable, and the patient now develops type 2 diabetes. And there is no optic chiasm threat. No, we have discussed this already, and I hope we all be able to answer it. Like, who will be agree with option A, option B, option C, and option D? Okay, because the patient has developed diabetes, and there is partial response to lanreotide. So adding pegvisomant will not only improve the control, but also control the diabetes. So if the liver is fine, it is safe, and routine monitoring is required also on pegvisomant, this option B goes in favor of it. Giving paclitaxel at this stage would lead to the worsening of diabetes control. Radiosurgery definitely is a third line last option. And cabergoline again is like it will do some benefit, but again the about 1/3 of these patients then responds to cabergoline, and diabetes will not be much affected or benefited. So the second line options thus include, it's very important to increase SRL dose or frequency. Now this off label, but when given in these trials, means like giving not every 4 weeks but every 3 weeks the maximum dose, one thing, or even increasing the dose, like lanreotide maximum dose is 120 mg, even 180 mg every 4 weeks was given. The side effect profile was same, and about 30 to 36 patients showed the improvement, those who were not controlled on the routine treatment. Adding cabergoline again in about 1/3 of patients reaches the goal, and this combination adding pegvisomant, if adenoma size is stable, very important, again I am telling, it can increase the adenoma size if it is already unstable. The response is more than 90, in fact more than 95%. So keeping eye on liver function test, it will also help to improve the diabetes control. And switching to paclitaxel again, if adenoma is a concern and diabetes is not an issue, then switching the first generation SRLs to paclitaxel, which has extended effect on multiple receptors, somatoreceptors. So about more than 15% response from octreotide. Like if the response to first generation SRL was 19% in the first 12 months, it increased to up to 31 to 33%. So putting these agents side by side, first generation SRLs in routine 40%, 17 to 80%. And if we shift these patients to oral octreotide, the 58% maintained the goal. Shifting to pseudotide, the response at 12 months was 19%, increased to 31%. And then SRL and pegvisomant combination, even more than 90%. So in the hardest cases, if the patient was put on pegvisomant or pseudotide at the second line, then we can combine these two. Remember, if we add pseudotide to pegvisomant, the dose of pseudotide requirement reduces about by 50%, and the response is seen in 67% of these patients. But again, the diabetes control may worsen and need to be taken care. And if the oral options fail, then the redo surgery or stereotactic radius surgery can be done. This gamma knife surgery takes years to effect, also has various other problems like hypopituitarism and secondary intracranial tumors, increased risk of cerebrovascular disease. And if the disease is aggressive, this is aggressive tumor, then the chemotherapy, alkylating agent temozolomide is an option. So 3 quick myth busters. Normal IGF-1 means the patient is symptom free, right? No, definitely, because 1/3 of patients show the clinical discordance between control and the quality of life. Routine yearly MRI is mandatory. False, because the adenoma size remains stable, but again, the case-based approach. On pegvisomant, follow growth hormone to judge the response. Obviously, the pegvisomant acts on the liver and does not affect the growth hormone level, so growth hormone cannot be used as a marker. On the frontier, the various models, AI models and MRI radiomics are very helpful, but these are not yet clinically validated. In these, the texture-based multiple images are drawn, and with 80% confidence, these tell the responsiveness of SRL. And AI phenotyping helps to decide the clue about the remission in about 80% of the occasion, pre and post-op pictures of hand and face. So 5 things to carry the disease, just a half minute. Treat the disease, not the number, that is not the IGF-1 value only. Follow the patient-centered and clinical-centered endpoints. Predict and treat, combine rationally, pick my comorbidities and treat complications. Thank you very much. Thank you for your patience.
One of the most valuable messages that I could gather from your presentation is management of acromegaly is steadily evolving towards individualized and targeted therapies, allowing us to improve all the 3 types of control you have just mentioned. Remember to scan QR codes that has been displayed on the screen for any question you may have. And now, coming to our final presentation, it is my pleasure to introduce Dr. Mujeeb Rahman, Assistant Professor Endocrinology at Hyderabad Medical Complex, Peshawar. He holds FCPS both in medicine and endocrinology, and very active research portfolio with more than 20 scientific presentations. Today, he will talk on indeterminate adrenal mass, tackling the diagnostic challenge. Please welcome.
Assalamu alaikum. Thank you very much for your kind introduction. And I'm really thankful to the organizing chair and the scientific chair for giving me this opportunity to present in front of you. So as you can see from the title of the topic, in the next 20 minutes, we'll be discussing adrenal masses. Adrenal mass is not a diagnosis. It's a diagnostic journey. Once you diagnose or see adrenal mass, then after this, the story starts. In the next 20 minutes, I'll be answering and you'll be answering these questions. Which adrenal masses are truly indeterminate? Which adrenal, in which clinical or imaging features will concern us towards malignancy? The imaging characteristics of a mass that will draw us toward malignancy. Which biochemical test should we perform and when? When to operate, when to observe, and when to seek additional images? And what are the common pitfalls that lead to misdiagnosis? So let's start with the clinical case scenario. A 25 years old female married with 3 kids presented with mild abdominal pain and fullness. And along with that, she was having some back pain. Initially, she had some weight loss, but in the last few months had weight gain, and that was not documented. She had regular cycles, no hirsutism. And she was having no past history of hypertension, but on that visit, her BMI was 20, blood pressure was 150/90. Her BLIs were unremarkable. She had some baseline investigation. Most of them were unremarkable, but her ultrasound abdomen showed some positive findings. And the ultrasound showed a 10.8 into 7.8 centimeter adrenal mass that was heterogeneous and with having some internal clot-like areas with increased vascularity. So now I would like to ask the audience, which next test would you like to perform to proceed further? Those who want to do unenhanced CT should raise their hands. MRI abdomen, hormonal evaluation, and refer to surgeon for intervention. So most of you are thinking that hormonal evaluation should be done. But what the guidelines suggest that we should do the unenhanced CT first. If you look at this CT, this CT is showing a lipid poor 7 into 7.2 centimeter. It's quite a big mass that is lipid poor. The Hounsfield units are 28. So a lipid poor left adrenal mass that is 7.7 into 7.2 centimeter. Again, you can see in the coronal section. So now we are dealing with a mass that by imaging phenotype, by no means it looks benign. It is something that most probably having some clinically and the imaging features are showing that these are some serious things, like the size of the mass is more than 4 centimeter, it's heterogeneous, and the Hounsfield units are more than 10, that is lipid poor mass. So in a lipid poor mass, size more than 4 centimeter, and which by no means looks benign. These are the clinical, the imaging features of the CT scan. 7.5 into 7.2, 28 Hounsfield units, indeterminate, not contrast, it's heterogeneous, and non-enhancing hypodense necrotic area in between. So this mass, which doesn't look benign and size is more than 4 centimeter, heterogeneous, lipid poor, what will be your next investigation? So majority think that C, definitely. So what the next step is? Next step is to assess the functional status of this adrenal mass. So what we did was, we did the overnight dexamethasone suppression test, and that was totally not suppressed. Plasma metanephrines were normal, so pheochromocytoma was ruled out, and then plasma eldo and plasma renin was normal, primary aldosteronism was ruled out. Her ACTH was suppressed, 7.93, along with a very high 24-hour urinary free cortisol. So till that, this mass, which by imaging phenotype was not a benign one, lipid poor mass, and that is secreting cortisol, ACTH independent. So ACTH independent left adrenal mass. We sent this patient to surgery and left adrenalectomy was performed. And the histopathology report turned out to be oncocytic adrenocortical carcinoma. And then this patient was referred to oncologist for further management. So when we come across any adrenal mass, we have to establish these two things. First, is it malignant? Is it functional? When we assess the functions, we always try to do these three panels. We have to check for the autonomous cortisol secretion. We need to do 1 milligram dexamethasone suppression test, plasma-free metanephrines or urinary fractionated metanephrines for pheochromocytoma, and then the for primary aldosteronism if there is any. if there is any clinical feature of primary aldosteronism. So mild autonomous cortisol secretion, where there are no clinical features, but the adrenals are producing cortisol independent of the ACTH. When we do workup for mild autonomous cortisol secretion, it is what we do is first 1 milligram dexamethasone suppression. If it is suppressed less than 1.8, it means that then it is normal. Along with that, the other test we can do is baseline DHEA sulfate. If baseline DHEA sulfate is less than 40, it means that the ACTH is not stimulating the ACTH. So we can go to the next step, that is 1 milligram dexamethasone suppression test. If DHEA sulfate is more than 100, we just need not to go further testing. Either we shouldn't do 1 milligram dexamethasone suppression test or with the higher doses of dexamethasone suppression. Similarly, DHEA sulfate ratio, the lower limit divided by the the DHEA sulfate ratio, DHEA sulfate level divided by the lower limit. If this ratio is less than 1.12, this is at least 99% sensitive for the mild autonomous cortisol secretion. So we can do the next step, that is 1 milligram dexamethasone suppression test, or even we can go for the higher dexamethasone suppression test if we think that is false positive, even 8 milligram dexamethasone suppression test. So the next case, we have a 24-year-old female. She was from Afghanistan. She had right flank pain and there were no features of Cushing, no hypertension, no palpitation, no headaches, no sweating, and there was no menstrual irregularity. Blood pressure was normal. Her weight was 55.4 kg. She was already investigated, and in her baseline investigation, there was nothing significant. She had a CT abdomen and chest, and CT abdomen and chest showed some positive findings. So CT abdomen showed a right adrenal mass that was 5 into 6 into 4.9 centimeter, although it was contrast enhanced image, so baseline house value rates were not determined. We discussed with the patient that we would like to do unenhanced CT, but because of affordability, the patient denied. So baseline characteristics on this image are suggestive of something that is not benign. It's hypervascular, it's heterogeneous, the size is more than 4 centimeter. So we did the biochemical testing. On biochemical testing, cortisol was suppressed with overnight dexamethasone suppression test. So max was ruled out, PO was ruled out having normal free metanephrine and normetanephrines. So if you look at the image was more than 4 centimeter, it was heterogeneous, and there were hypervascularity. So few is ruled out, max is ruled out, and then this adenoma was not benign by any mean. So the only thing which we are left is our differential is adrenocortical carcinoma. So what will be your next step if you want to do next test? Which test would you like to do? Would you like to do the biopsy, FDG PET, proceed with cardiothoracic surgery, right adrenalectomy, or measurement of steroid precursor? So serum steroid profiling in the diagnosis of ACC, if we suspect that this patient is having ACC, so 3 to 8-fold higher ACC, 3 to 8-fold, these steroid precursor, 11 deoxycortisol, 17 hydroxyprogesterone, 17 hydroxyprogesterone, they are 3 to 8-fold higher in adrenocortical carcinoma in masses that are having more than 20 Hounsfield units. So we do not have these tests, but we should have done these tests. And then this patient was referred to surgery, and the histopathology report turned out to be adrenocortical carcinoma. So these are the imaging features of adrenocortical carcinoma. It's irregular shape, inhomogeneous tumor calcification will be there, diameter is more than 4 centimeter, it's unilateral location. So these are the imaging features of adrenocortical carcinoma. They usually present with hormone excess and some with mass effect, and among the hormone excess, cortisol secretions are 30 to 40% and mixed are 35 to 50%. So if you look at the landscape, majority of the adrenal masses are benign, more than 90%, 6% are max, 3% FEOs, and 2.6% with malignant primary or secondary, and 0.6% may present with primary aldosteronism. So again, the same thing, we have to establish functioning status and the imaging phenotype of the adrenal mass. If the unenhanced CT is the basis, so if it is less than 10 Hounsfield unit and the mass is homogeneous, no need to do further testing, it's benign. If it is homogeneous, Hounsfield units are 11 to 20, it's less than 4 centimeter, either we can wait for a year or we can do additional imaging. Here the indeterminate area is where the Hounsfield units are 11 to 20 and the size is more than 4 centimeter. When the size is less than 4 centimeter but the Hounsfield units are more than 20, or if the size is less than 4 centimeter but it's heterogeneous, here we need to do further imaging. The further imaging are like we can do washout test, washout CT, and then FDG PET, or even MRI with signal shift. Masses which are more than 20 Hounsfield unit and more than 4 centimeter or more than 4 centimeter heterogeneous, they should go to the surgery after having MDT discussion. So these are the second line investigation or imaging modalities: washout CT, MRI, chemical shift, or FGG PET. Or if we are sending someone for the biopsy, before doing biopsy, it shouldn't be ACC. Adrenocortical carcinoma should be ruled out, and the patient should not be having hormone excess, especially pheochromocytoma, and lesion cannot be characterized by imaging. And then if we do the biopsy results will change the treatment altogether. So we had another case. This was a young guy. He was having hypertension and under treatment since 2024 from one doctor to other doctor, and in between he used to have all fine and he shouldn't go to the consultation. So in 2024 he had these two investigations along with other baseline investigation. Ultrasound showed an adrenal mass 3.9 into 3 into 3.2, while the renal Doppler showed normal renal. It was for renal artery stenosis, it was normal. So on the basis of the ultrasound finding, what should be the next step? So unenhanced CT. We did the unenhanced CT. The unenhanced CT showed right adrenal mass. It was 4 into 4.3 centimeter. The pre-contrast, it was 30 Hounsfield units, almost a lipid poor mass. And on further contrast, it was 140, and portovenous 100, and late contrast it was 50. And then the contrast washout studies were calculated. If you look at these washout studies, absolute washout is more than 60%, that is 70%, and relative washout is 50%, again more than 40%. So by looking these values, an adenoma that was lipid poor, more than 4 centimeter with these washout period, a radiologist will definitely say that this is a lipid poor adenoma, benign, but it's not a benign one. Any lipid poor adenoma with these washout periods, because nowadays the recommendation are the washout studies are not that reliable. They can miss a lot of pheochromocytomas because they have high vascularity and they have high washout. So in this, as it was suggested by the reading, that it is benign lipid poor adenoma, but the functional study shows that this patient is having a very high norepinephrine levels, more than 19 times the upper limit of the normal. So this patient was referred to surgery. So these are the imaging characteristics of pheochromocytoma: increased attenuation, increased mass vascularity, high signal intensity, cystic and hemorrhagic changes, variable size, may be bilateral. So this is nowadays the pheochromocytoma majority, they are diagnosed not by the typical symptomatology, they are diagnosed by the incidental finding with the genetic finding. More than 70% are diagnosed in this way. While this thing should be kept in mind that pre-symptomatic few are there. When the factory is small, they are not producing that much catecholamine, so pre-clinical fews are there. So this is another case. It was again 24-year-old female having all these features: hypertension, abdominal pain, anemia. Ultrasound showed a 9.6 into 6.4 centimeter adrenal mass. And then we did CT abdomen. CT abdomen shows a 7.7 into 6.7 centimeter. Pre-contrast, it was 28, that is lipid poor mass. If you can see 28, and on contrast it's hypervascular, take a lot of contrast, and then there is positive washout. And the biochemical testing showed that this is catecholamine producing, while the VMA were very high, 24 are urinary VMA. We usually don't do, and the guideline doesn't recommend VMA levels nowadays. Guidelines suggest that we should do the plasma-free metanephrines or 24-hour urinary fractionated metanephrine levels. This patient was sent to surgery, and it turned out to be pheochromocytoma. So 40% are few associated with genetic testing. We should consider genetic testing as well. And these are the three clusters where majority of the genetic the groups are in these 5 genetic groups. So 95% of the genetic changes and mutation occur in these 5 groups. So among the standard of care, those higher with the high Hounsfield units more than 4 centimeter, heterogeneous, they should straight away go to the surgery, and benign lesions should not go to the surgery, and there the surgery is not indicated. Max and indeterminate lesions are considered for further localizing study like FDG PET scanning and MRI signal shift imaging, and then we can do the other imaging. Thank you.
Thank you very much, Dr. Mujeeb, for giving us such practical framework. And one of the key takeaway is that indeterminate adrenal mass should never rely on only a single investigation. Rather, it should integrate an approach having imaging, biochemistry, and multidisciplinary clinical decision making. So, coming towards the end of session, we have received some questions for our speakers. May I ask them one by one? First question is from Dr. Umair Ashfaq. The question is, can you tell, please, normal if the prolactin levels are normal in growth hormone secreting adenoma, would cabergoline still help? May I repeat the question?
Can you listen? Thank you. The answer is simple, that the D2 receptors are present on the adenoma, and the response is definitely seen even if the prolactin is normal. However, if the prolactin is also high along with growth hormone, the response will be even higher, up to 35 to 40%. Otherwise, the response may be expected up to 25%.
Thank you very much, Dr. Umair. A second question is also from you. So it's a question regarding paclitaxel-induced diabetes. That what is the best treatment option for that in that situation?
That's a very important question. And let's split it further, like best treatment, first treatment, and safe treatment. The best treatment, because paclitaxel acts on the subtype 5 receptor somatostatin on the pancreatic beta cells. So insulin and incretin levels decrease. So the best treatment would be a GLP based therapy. But if the diabetes is mild and can be controlled with metformin, so that is considered a first line treatment. And the safe treatment, the safety, like the patient has also other comorbidities like cardiac, renal, but be careful while giving SGLT2 inhibitors because the pancreatic beta cell function is suppressed, insulin decreases and growth hormone increases the lipolysis, so the ketogenic substrate is available. So risk of DKA as well as euglycemic ketoacidosis increases with SGLT2. So that is a bit a relative contraindication, but can be given with close monitoring.
So thank you very much. I
Thank
have
you.
received another question. What to do in patients who can't afford? Dr. Umair, this is also from
Ji.
you. There are a lot of questions. The audience
My
were very
pleasure.
interested in your presentation, I guess. What to do in patients who can't afford octreotide post-surgery and radiotherapy in Pakistan? Because we are resource-limited country, I think that's why this question is putting up.
All right. So that is very important that the cost barrier is a big issue. But again, choosing the right drug at the right time with the best interest of patient and affecting the comorbidities and looking at the percentage of response with the IGF-1 and as well as the adenoma size and glucose control. So if cost is an issue, then cabergoline is an option out of the available options. In fact, the available options are octreotide LAR, which is a bit costly, definitely. The other option remains cabergoline, but be realistic and inform the patient about the expected outcomes as well.
Thank you very much. So other question is for Dr. Usman Musharraf. It has been asked that what are the indication of combining fenofibrates with statins?
Yes, fenofibrates can be combined with statins. Obviously, there is some increased risk of obviously myalgias and myositis, but that is not clinically significant. But what option we will have if we don't combine statins and fibrates in patients when triglyceride levels are still high after we have achieved our LDL and non-HDL goal in patients with mild to moderate hypertriglyceridemia? Because the modern drugs, one of the drug that is obviously omega-3 fatty acid in its pure form, EPA, that is not available over here in Pakistan. And number two, the options I have discussed, the olezarsen and obviously the plozasiran, ApoC3 inhibitors, they are too costly to give for these kind of patients, number one. And number two, they are approved for resistant cases of severe hypertriglyceridemia and for severe cases of chylomicronemia.
Thank you very much, Dr. Musharraf. Now, before we conclude this session, I may request valuable remarks from our chairpersons. May I request Professor Zaman Shaikh first, your comments?
And I believe
True
that
that.
his lecture must be very nice. Regarding triglyceride, we often forget the importance of triglyceride is compared with LDL, which is most dangerous villain in medicine. Although triglyceride, it is responsible for visceral fat, central obesity, and free fatty acid, and of course pancreatitis. So we should take this as important component to be treated as early as possible. Dr. Umair Ashfaq talked acromegaly very well, and Dr. Mujeeb Rahman also talked in a form of 4 or 5 cases about adrenal adenoma, suspicious. Now, there are 3 generations of endocrinologists. First one, founder, members, and very senior members. And number 2 is major chunk. And third one, those who passed FCPS endocrinology recently in last 4 or 5 years. So it is very nice to see second generation taking over very successfully. All these seniors. So I congratulate all the young generation, especially this time from KPK, majority of them, but from all over Pakistan.
Thank you very much, sir. May I now invite Professor Khalid Usman for your valuable remarks.
Excellent presentation for all the speakers. And looking at the lectures, it reminds me that, endocrinology is just not merely just to see the things, but you really have to think over it.
True.
Because you see a lot of things which are hidden. And just like not every incidentuloma needs surgery, not every, acromegaly we will treat it. The aim should be quality of life. The same is, just like Nadeem mentioned about, the dilemma is that our BMI is 23, visceral fat and everything, still we are at high risk. So before we develop the risk and before we develop any complication, I think we should screen those patients who are at high risk. So it was an excellent presentation, and all the speakers, they've covered everything in detail.
Thank you very much, Professor, for your valuable remarks. Now, finally, may I invite Dr. Waqas Shafiq
No, thank you
to share his reflections.
Thank you very much. I think all the talks were brilliant, especially Nadeem. I think his presentation, his style was very good. So we must say that was excellent. Regarding the pituitary tumors, acromegaly, I think acromegaly is one area which we all feel the management is poor from our side, not because of expertise, because of the cost, because even if we talk about the lendiotide, octreotides and all those things, their availability and the cost is a challenge. And that's one of the reasons that Pakistan Endocrine Society, when they put a guidelines, we put radiations, either stereostatic or we can call gamma knife or cyber knife, etc., as a second line rather than the medical treatment. Although those who can afford, then medical treatment is still going to be the second line, but those who cannot, then radiation can be an option. Regarding the adrenal lesions, I think incidentalomas are very, very common, especially when we are getting imaging, very common. So we are all going to face this very regularly. An important point is to make sure that they are not malignant. And the second most important is that they don't secrete, especially consider screening for pheochromocytoma by doing metanephrines. So all the talks were brilliant. One small point I want to make is when making presentation, please ensure the confidential details of patients are hidden, because that sometimes is not a good thing to be shared. But everything was brilliant.
Yes. Thank you very much, sir. Very thoughtful of you. Ladies and gentlemen, as we come to the end of this enriching session, I extend my heartfelt gratitude to our distinguished speakers, our respected chairpersons, to share their expertise and guidance, and each one of you for such a wonderful audience you have been. So what we know is a drop, what we don't know is an ocean. May we all continue to explore that ocean with humility and lifelong passion for learning. Thank you for being such a wonderful audience. It has been truly a privilege and honor to moderate this session. With that, I have now the pleasure of handing over the proceeding back to Pakistan Endocrine Society, Dr. Rimsha Azhar, for the next session. Thank you once again, and I wish you all for the very productive remainder of the session. Thank you very much.